morning, welcome to Golden Park Theatre today. Today we have an interesting case for you. We have a 45-year-old male patient. Patient has got severe back pain for the past 3 years. The back pain is horizontal in distribution, does not radiate. Patient has no stenosis symptoms, no claudication, but persistent backache. Patient cannot even sit for 10 minutes. If patient tries to walk, after a period of 5 or 7 minutes, the pain in his back increases and the patient is forced to sit down. When he sits down after 10 minutes, again the pain in his back increases and leaves him uncomfortable. Patient has undergone a serial number of MRIs. Patient is having a high intensity zone in his lumbar spine at L5S1. I will now show it to you. As you can see here, the L5S1 disc compared to the other discs is a black disc, and there is a high intensity zone seen in the posterior part of the L5S1 disc. As you can see in these actual images, the disc has lost its normal concavity. It has bulged out, and if you can zoom a little closer, you will see the annular rent lighting up like a white band across the canal. This signifies the high intensity zone and the annular rent. This has been reported by the radiologist, but unfortunately, attention to this has not been paid by the treating doctor till now. Today we intend to change that story. What is a high intensity zone? A high intensity zone is basically a tear of the annulus. When the lamellated fibers of the annulus tear, discal material protrudes within that tear. The nucleus tries to enter into the annulus. Part of it undergoes mucoid degeneration, and this gives rise to a high intensity signal in the posterior part of the disc. Basic pathology of pain as an endospine surgeon we understand is the annular rent. This collection of fluid signifies the body's response to that tear. There is vascularization of that tear, there is neuralization of that tear, and there is collection of all degenerate mucoproteins in that tear. Now this tear may be leaking microscopically and exposing the dural sac and the root over there to chemical irritation. What we intend to do today is to do a provocative discography, wherein we will put in a needle into the L5S1 disc. After we put in the needle into the L5S1 disc, you will observe for yourself as we inject the dye in the back, the patient will suffer from severe pain. Back pain will be a prominent complaint of the patient, and we will on the image intensifier check for the spread of the dye. If the dye leaks posteriorly into the dural canal, it means that the tear is complete, that this is the notochordal protein which is now causing chemical irritation to the root and the dura. In such a case, we will go in and put in our scope and clean out this tear. Thank you. Let us start. We have marked the center line, the interspinous line. After that, we have marked the disc line. After marking the disc line, we measured the disc height after compensating for the lordosis. As you can see, the disc height, the height disc line is a little anterior to the AP line. The lateral line is a little higher to the AP line. This gives me my entry point, which I have adjusted, and now you can watch over there. You can see that in the AP, I am bang in the center. I have reached the interspinous line. In the lateral X-ray, you can see that I am in the posterior 1/4 of the disc. In the AP, you can see I have reached the interspinous line. Now I will start with doing a provocative discography. Shoot. And I'm going to push in the dye. As you can see over here, with very gentle pressure, hardly any strength being needed, I'm able to push the dye. And you can see the dye posteriorly. You can see the spread of the dye in the disc, and you can see that it is falling in the canal. It is coming down almost along the S1, S2 roots. This is a classical annular tear, annular rent with the dye pouring posteriorly. I have already injected the dye. I was able to push in about 5 cc of dye. very comfortably into the disc. John, can you move aside please? As you can focus over there, you will see that the dye has leaked posteriorly into the canal, and patient has confirmed that he has severe backache when we push in the dye. This is a positive discography, it's a provocative discography. Since it's a positive and a provocative discography with the dye leaking into the canal, we will now be proceeding with our regular endoscopic decompression of the spine. We will be visually identifying the annular tear and removing all the nuclear material from it and doing an annuloplasty. Thank you very much. As you can see, I have just put in my scope and I have pulled out a fragment. Now if you please focus upon this fragment, come close and focus on it. Come close and focus on it please. You can see the fragment is red and vascularized. There's a huge fragment removed by the scope and the grasper, but it is a vascularized fragment. It is red in color. This shows that the annular tear, the body was trying to repair it, but this huge piece of nucleus was within the annulus and not allowing it to heal. Thank you. Of me over here. The bleeding is coming from the rent. Can you see the rent please? This is the rent in the annulus, which I am now pointing with my hook and probing with my hook. It is from this rent that the patient was getting chemical sensitization of his cord and was getting pain. We have done a clearing of this entire rent. There are no retained fragments over there now. I am hooking the tear, I am opening it up further, and I am making sure that there is no fragment retained over there. This was the annular rent which was causing the patient all his complaints. Thank you.